in listen-only mode.
Good afternoon and welcome. This is Corey Curl. I'm the Associate Executive Director at the Pritchard Committee. I see many friends and colleagues have joined us today, so thank you so much. This is the first webinar I think that the Strong Start Kentucky Coalition has had, so thank you so much for helping us be a part of this new model of engaging with all of you. We're very excited today. We have Dr. Corinne Williams from the University of Kentucky. She's going to share the latest information on HANDS, which for those of you who may not know is Kentucky's voluntary evidence-based home visiting program. The Strong Start Coalition has been instrumental in securing support for the program and for high quality standards for the program for many years, and it continues to be a major priority for our coalition members. If we have time today, following Dr. Williams' presentation, I will go over a couple of updates for Strong Start. But before we begin, I want to share some housekeeping information pertinent to the webinar. First, we will have time for questions and discussion after the presentation. We will have the phone lines on mute so that we have the audio clear throughout. But as we are going through the presentation, if you have questions or comments, please type them into the chat box and we'll address as many as we can. You can also, there's a little hand button, and if you press that, then I will see you and you can actually voice into the webinar and ask your question or give your comment. We are going to record the webinar, and so we'll be able to send it out to you afterwards. So with that, I'm delighted to turn it over to Dr. Corinne Williams.
Great. Thank you very much for having me here this afternoon. And just to let you guys know my agenda, the plan is over the next 20 minutes to give you a quick tour of the work that we've been doing over the past 5 years to evaluate the HANDS program. So in some cases, I'm going to move through things quickly, but feel free, as Corey has said, to ask questions and keep notes along the way if you have questions. I am at the University of Kentucky, so one thing to note about my role is that I am an external evaluator for the HANDS program. And what this means is that I really am independent of the program, which means I've been able to explore lots of interesting data with this, looking at HANDS. So I started working with the project in 2011, and back in 2011, with the receipt of the McVie funding at that time, we first had to develop our benchmark plan, which involved developing clear constructs that we would measure in the 6 benchmark areas that are listed on this slide. We had different measures under each of these 6 benchmarks. As part of the initial funding, the goal was over 3 years to track improvement and see if over 3 years we could demonstrate improvement in each of these 6 areas. As part of the McVie funding, we also had to develop a separate evaluation plan that met the rigorous criteria of the evidence-based review process, which I'll describe actually toward the end. And then independent of that requirement by the federal government, one of my first mandates from the HANDS program was to conduct studies that would hopefully lead to the overall HANDS program being deemed evidence-based. And as an update, we are currently working on our final evaluation reports that are due in January. So some of the data that you're going to see here is actually preliminary, but I still wanted to share it amongst this audience. As part of my work, we've been working with lots of data on several outcomes, and we have conducted 2 primary quasi-experimental studies that I'm going to describe using the statewide HANDS data looking at first-time parents. One of the things that's important to note about HANDS is the way things have worked in Kentucky with the legislation. It's really hard to do a randomized control trial because we do have funding to serve every person who wants service, every family that wants services in Kentucky. And so we are limited to doing these quasi-experimental studies, just as a note. I have described a little bit here the 2 studies. We worked first with 2008 data, where we compared HANDS participants to women from the birth certificate data. And then in 2011 and 12, we compared them to families that were referred to HANDS but didn't participate. And these 2 comparison groups have different benefits and strengths and weaknesses. And I can talk a little bit more about that if you're interested. But the key point is that for both of these, the comparison group is matched on key demographics. So they are quite similar to the HANDS participants, women who actually are families that got a home visit, demographically in terms of race, ethnicity, education, insurance status, things that we know are important. We're also, as part of that McVie funding, we're conducting an official evaluation of the HANDS program among multi-gravida women. And we are really interested, because first-time parents are so often the target of home visiting programs, if you could see similar outcomes among multi-gravida women as we do in the first-time moms. And then finally, as has happened over the past 5 years, we have worked on some other small studies on other outcomes of interest that sort of pop up. If there's data available on a question that we're interested in, we'll look at it. So today I'm going to show you some preliminary data we've been looking at related to infant mortality and kindergarten readiness, which is hopefully going to be fun. This slide gives you way more detail on the study participants that you may or may not want to know for each of the 2 evaluations. The take-home message is that in any given year, HANDS has about 7,500 women or families that are referred to HANDS. And so for both studies, we have about that number. And then overall, we ended up with right at 2,000 HANDS participants that we were able to identify as having participated in HANDS, received at least 1 home visit, and then we're able to identify a perfectly matched control for that person. One of the things that's important to know about HANDS, and I think I am forever singing the praises of HANDS, is that these studies represent some of the largest studies of home visiting that have ever been done. HANDS, we have a tremendous amount of data, so we are able to look at a large number of women and see how it works among different groups. In the next few slides, I'm going to show you some of the outcomes we have examined to date. And I want you to be aware of the different comparison groups because I will show you sometimes data from 2011 to 12 and sometimes data from 2008. If I only show you one set of data, it's because the results were consistent between the 2 studies. And then officially, one thing to note is that study number 2, the data from 2011 to 12, is what was submitted and is accepted as documenting the evidence base for HANDS. That is actually the data that was used for that, and I will show you that at the end. So to start, we looked at birth outcomes, and this is showing the 2011 to 12 data. And not surprisingly, HANDS participants, and this I think has been shown in every single study of HANDS to date, regardless of population, HANDS participants have lower rates of low birth weight infants and lower rates of preterm delivery. Both of these differences are statistically significant. All of these slides are going to look the same, where HANDS participants are in orange, or the column on the left, and then the comparison group is in blue, or the column on the right, and then I've included the p-value at the bottom, so you can see whether or not it's significant. If it's less than 0.05, it means that it is, in fact, a statistically significant difference. And here, I think even just looking at these numbers, to have a low birth weight rate of only 7.2 among our HANDS participants, that's a tremendous accomplishment. Interestingly, when we looked at prenatal care, we saw no difference in accessing care during the first trimester. And once we started to think through the referral process for HANDS, that actually probably makes sense, and that's not likely an outcome the HANDS home visitors are able to change. What we do see is that participants in HANDS are more likely to have adequate prenatal care. That is, they continue to go to their prenatal care visits throughout their pregnancy on the recommended schedule according to the ACOG recommendations. And we saw this both for 2011 to 12, and then for 2008, we saw the exact same difference. The relationship is actually slightly stronger in those early participants comparing to the birth certificate comparison sample. And then, because I like to play with data, we looked at a few different maternal health outcomes. So we looked at pregnancy-induced hypertension, which we saw was dramatically lower, and also maternal complications during delivery. And we think this is probably related to accessing prenatal care regularly, being able to talk with someone about what to expect during delivery, and have some of those health conditions addressed earlier in the pregnancy versus sort of coming in to delivery with maybe less access to prenatal care. And then we also looked at WIC, and for this we were really interested in, are the HANDS home visitors helping to get women connected to services, because that is part of their role, and this is one that we could look at using birth certificate data. And we do see actually that HANDS participants are much more likely, significantly more likely to indicate maternal receipt of WIC. And our assumption is that most of these moms, given their demographic characteristics would qualify for WIC. Anyone in Kentucky who qualifies for Medicaid to pay for delivery automatically qualifies for WIC during the pregnancy. And so that for us was, again, evidence of hands working well. And then finally, this is something that we were a little bit surprised by. We looked at breastfeeding in both studies, and in 2011 and 12, we saw no difference. And actually, the hands rate technically looks a little lower, but really, this is statistically, these numbers are exactly the same. So we didn't see an impact with hands compared to the comparison group of women who were referred but didn't participate. And we thought that was surprising, in part because, I'm going to go to the next slide, in 2008, we actually saw the exact opposite, which is that hands participants were significantly more likely to breastfeed compared to the comparison group that was the birth certificate only, just a random sample of moms. And so this is something that we are planning on exploring further, and we think is important to consider thinking about how important breastfeeding is for child health. But that is one area where we saw different findings. And then lastly, and I think really we were, again, I feel like we're so happy with all of these results, but to see the substantiated reports of child maltreatment were significantly lower among the hands participants, about half as likely to have a substantiated report. And I will say, we looked at this data, we had both unsubstantiated reports and substantiated, and these children actually had closer to the same number of any report. And so it does seem like it's really that these reports are not being substantiated, where there might be concerns, but there is no evidence of actual abuse. And most of these are, we've actually tried to look at the sub-analyses, most of these are neglect. It's really hard in the younger population to look at other types of abuse. I'm going to switch now to talking about our Multigravida program. I told you this is going to be a quick tour through some findings. So as part of the McVie grant, we expanded hand services to include families that were not first-time parents. And this was, I think, really unique at the time, and is still a unique contribution that we're able to make to the literature. Because of the timing, in 2011, HANDS was not yet evidence-based. We actually had to pair with Healthy Families America, which was an evidence-based program at that time. And we implemented what we referred to as HFA HANDS. And so I will refer to these mothers as either HFA HANDS participants or often just McVie participants. I try to be consistent, but I, in my own head, I say them interchangeably. Because so many home visiting programs, as I just said, only serve first-time parents, we were really interested in whether or not we could improve health outcomes among multigravida women participating in home visiting in the same way that we've seen those effects that I just described among the first-time parents. And so for this work, we actually decided to do two comparison groups. We're comparing multigravida women who received home visits to those, to multigravida women who were referred to HANDS but didn't have a home visit, or at least did not have a prenatal home visit. And then we're also comparing them to first-time mothers who participated in HANDS and received home visits. And for this study, or for that comparison group, what's important is that here we're actually hoping that we don't see a difference. We would love to see that our multigravida mothers having similar outcomes as our first-time mothers, seeing the same improvements in those two groups. And just in case people weren't aware, this is the site of the counties that were served by McVie. Anything that is shaded in either the blue, purple, or pink were counties that were able to serve multigravida families. As of, I want to say 2015, we're now actually, recently, we're able to serve multigravida women in all counties, but this was the ones that were served during the grant period. And this is the data that I'm going to talk about comes from these counties specifically. Our grant period ran, or the study period ran from October 2011 until September 2014. And in this time, 19,000 women were referred in those counties that I just described to HANDS, or HFA HANDS. 4,000 of these were our multigravida parents, and then about 15,000 were the first-time parents. And then of these, we were able to match about 14,000 to their birth certificates. I should have said all of this data we are using comes from birth certificate data as administrative data, so we're not relying on self-report. And then of those that we were able to match, about 7,500 had ever received a home visit, and 5,700 of those had actually had a prenatal home visit, which is what we were looking at in terms of the birth outcomes, what we were really interested in. 1,700 of these were the McVie HFA HANDS, and then 3,900 were the non-McVie or HANDS first-time parents. And then for this, our comparison group is, the McV comparison group was 1,510 families, and we included either families who would have been McV participants but chose not to participate, or they were families who only received visits after the child's birth. And then for this, I'm going to show you some of our benchmark data so you can get a sense of the constructs that we looked at, and then the maternal and child health outcomes from the live birth certificate records, including low birth weight, preterm deliveries, NICU admissions, and breastfeeding. So this is a chart similar to what we had to prepare for our benchmark data. This one is looking at adequate prenatal care. And our goal was to increase the percentage of women, increase or maintain the percentage of women receiving adequate prenatal care. And what you see here is that across all 3 years, about 80% of women received early and adequate prenatal care. And I've included at the bottom of the slide the Healthy People 2020 goal, which as a country, our goal is to increase the proportion of pregnant women who receive early and adequate prenatal care to 77.6%. And I think it's really important to note that HANDS did better than this, and this is a relatively high-risk population. So I think that's a huge win as far as I am concerned. And then we also looked at interbirth intervals, which is the proportion of women reporting pregnancy at 12 months postpartum. We know that ideal birth spacing is 18 to 24 months, and there can be complications if those children are born too close together. I think also for child development, it can be challenging to raise two children very close in age. And here you can see we did make improvement. Here we want to see a decrease, so we're decreasing the number of women who are reporting a pregnancy, and so we actually were able to decrease that by about 4% over the year. And then one of the other, I picked some random things that I thought were interesting and would be interesting for the, is depression screening, because we know that moms who are depressed may not interact with their children in quite the same way and may not provide those educational activities in quite the same way. And so we implemented, we had already been doing depression screening, but we were monitoring it much more closely. And so here you can see over the 3 years, we did increase it from just under 80% to over 90% having depression screening at enrollment of HANDS. As part of this, we also had the Moving Beyond Depression program, which was providing in-home cognitive behavioral therapy in certain counties. And so that was the other reason where this was a really important marker for us, because that really does then change the dynamics of those women and the interaction between those women and their children. And then I included this one because it's my personal area of interest, which is looking at domestic violence screening. I think similarly thinking about providing safe and nurturing environments for children. And so this was, in year 3, we did make a very concerted effort to work with the home visitors on screening and then what happens after. And you can see we did dramatically increase the rate of domestic violence screening in this population. And then I'll orient you, this slides, they're going to look exactly the same, but the bottom has changed a little bit. So now we have, on the far right column is the McV participants. Those are the multigravida women who were served, got a home visit. The middle column is the home HANDS, the first-time moms who received a visit, and the comparison group are those multigravida women who did not receive a visit. And the next slides are all going to look just like this. And what you see here is, this is looking at low birth weight. On this slide, I forgot to include the p-values, but the difference between the McV participants and the McV comparison is in fact significantly different. Or again, similar to what we saw for the first-time moms, our McV participants do in fact have a lower low birth weight infant rate than do the comparison group, which is again a huge win for the HANDS program. And then similar to what we were hoping to see, there's actually no significant difference between the first-time parents and the multigravida parents. We saw about the same rate. That pattern holds true also for preterm birth, not surprisingly. So we see that the McV comparison group has the highest rate. The McV participants are significantly lower, and there's no statistical difference between the first-time parents and the McV participants. And these numbers, it's a little harder to tell, but I'm going to ask you to trust me that the statistics bear it out, that there is, in fact, a significant difference between that 7.1 and the 8.3. The babies of HANDS participants are much less likely to go to the NICU. There is no difference between first-time and McV participants. The one area where we do see differences, and this gets back again to the issue we had with the first-time parents looking at breastfeeding is here we actually do see that the comparison group has lower rates of breastfeeding than the McVie participants, comparing the column on the far left to the column on the far right. That is a statistically significant difference. And actually McVie participants also have a statistically significantly lower rate than first-time parents, which that actually holds true in general. You see that there's slightly fewer women who will breastfeed a second baby at the population level than first-time moms. But we do still see here that the McVie participants were more likely to breastfeed than the people who did not have a home visit. So that was a very, again, quick whirlwind. So we see, again, McVie participants had better health outcomes compared to women who did not have prenatal home visits. Fewer preterm births, fewer low birth weight infants, fewer NICU admissions, and then increased breastfeeding. And then compared to first-time parents who received the prenatal home visits, McVie participants had similar health outcomes with the exception of breastfeeding, but I think that we can understand those differences. I'm going to now go quickly, if I haven't been going quickly already, through two more studies, one on infant mortality and then one on kindergarten readiness. And so, as I'm assuming most people know, the infant mortality rate in Kentucky is higher than the U.S. national average. Lower socioeconomic status correlates in part with higher risk of infant mortality, in part due to inadequate prenatal care. And there has been some evidence that early initiation of prenatal care and then home visiting programs can actually reduce infant mortality. And so what we were interested in looking at is whether or not HANS reduces infant mortality. And so we used HANS administrative data and then data from birth and death certificates from 2005 until 2014. So it's a very large group of infant deaths. And what we did was we matched the death certificates to the HANS administrative data to identify women who had received at least one HANS home visit, and then to identify women who were referred to HANS but didn't get a home visit. I'm going to come back to that group because that's that voluntary piece again, so people can choose not to participate. And then all other women. We are doing continued work on this to tease out that all other women to identify demographically similar, but for now they're just grouped as all other women. And then infant mortality rates were calculated as number per 1,000 live births. So if you look at this graph, it's your first instinct is going to be to say that HANS isn't working because the infant mortality rate of HANS participants is higher than for Kentucky births. It's 10.86. And what I actually think is the take home, and I have sat with this for a few months, I guess, at this point. If you look at that comparison group of the HANS referred but no visits, it's 26.9. And so my guess, my hypothesis would be that without HANS, you would actually see a much higher rate in that population, and that HANS is actually working to decrease the rate. We might not have gotten all the way to the state average or lower than that, but this is progress. So I think that was my take home of this, was that while it is higher than the state average, given it's a high-risk population, I think that is actually showing some significant improvement. So this study provides evidence that home visiting reduces infant mortality, I think, at least in a high-risk population with a large sample. We have about 3,000 infant deaths that we're looking at here. One of the things that I do think is a challenge is there appears to be a significant missed opportunity for preventing infant deaths among those who were referred but did not engage with HANS. And I think that still comes down to it's a voluntary program and we can't force them, but thinking about how at least at that moment of interaction, is there some way that we could provide some sort of brief intervention, something like that. And so while the infant mortality rate among HANS participants remains higher than that of what I call low-risk women, it is significantly lower than a demographically comparable population that did not participate in HANS. And then last but not least, kindergarten readiness. And I think this is probably the thing that this audience may be most interested in. So we know a lot about kindergarten readiness, or why it's important, thinking about it as really education as being the most cost-effective intervention to improving health and reducing health disparities. And so we know there's this pathway that students who come in at third grade are more likely to not come in not prepared at third grade, or more likely to not complete high school. There have been studies that have looked at socioeconomic status with this, and I think this is the exact thing that HANS is trying to intervene on, is trying to teach parents how to engage with their children, teach them the developmental activities that can then improve educational success. And there have been a few studies that have looked at home visiting to show that these children whose families participated in home visiting programs have had higher test scores later on. And so I was fortunate that we were able to obtain data, and this is a very small study. Let me go ahead and say that, and it's preliminary. We're still working with the data a little bit. We obtained data from 2 counties in Kentucky. One county we actually had 2 years of data, and then the second county we just had 1 year of data. But we had a total sample size of 632 kids who we had kindergarten assessments for, and of these we were able to match 575 to both the birth certificate data and the HANS data to figure out their demographics at birth, and then whether or not they participated in HANS. So we had 72 of these 575 who participated in HANS, 45 were referred to HANS but did not participate, and then 458 had not been referred to HANS. And for this we're using the Brigance score, so we have a composite score, and then we have the 5 dimensions of readiness. And so we're looking at, were they ready, not ready on the composite, and I included the ready with enhancements, I think is the, as ready. I'm going to go back and look at that. That's, again, this is preliminary. And then we looked at the 5 dimensions of readiness, whether or not they were above or below average, or above or below average. And what you see here, and this is, again, it's going to look very like the infant mortality, HANS participants are not doing quite as well. This, I will say, the numbers I'm presenting on this slide are not adjusted for anything. But we see overall there is actually, it looks like they're doing worse. There's actually no statistically significant difference between any of these numbers on the slides. And actually, when you control for sociodemographics, race, ethnicity, insurance, maternal education, and maternal age, there is no significant difference. And I actually forgot to say, I have Sarah Seepreck in the room with us as well. She's my research coordinator. And we've talked about this a little bit, thinking about what it means to have no difference on this study. And if you think about these children as a high-risk group, to get them up to the population average is actually probably a win. And we might not expect them to excel or go beyond the population average, but I think even just getting them there, where they are on par with their their counterparts, their peers, is a huge win for the HANS program. I would love feedback on this. This really is preliminary, so any thoughts you have are more than welcome. And so I said, despite the high-risk status of the HANS families, their educational outcomes are comparable to the rest of the community. And this is a very small pilot study. It's 2 counties who might have unique issues, or not issues, but unique characteristics that wouldn't maybe not generalize to the state. But we are hoping at some point maybe to do this at a larger scale. And then I just wanted to spend a few minutes to give you guys some information on the Home Visiting Evidence of Effectiveness Studies Review. And so this is the process, and I think this is an important thing to think about, particularly with some of the policy changes that have been happening, and with HHS, what their plan is with this. And so when all of the funding came through and this started, they developed the Home Visiting Evidence of Effectiveness, we call it HOME-B, review process, which was designed to conduct thorough and transparent reviews of all home visiting programs. And what they wanted to do was have standardized, strict criteria to help ensure that we're judging all of the programs the same, and that what we actually observe is the difference the program makes in health outcomes. And so they review both randomized controlled trials as well as quasi-experimental studies that meet these criteria. I spent hours reading. There's probably 300 pages of documentation about what all the criteria are. I'm not going to bore you with that level of detail, but it is available on their website. The other thing that's available on their website that I think is really important to look at is the different outcomes of different home visiting programs. You can see every program they've ever reviewed and see what they found, what they rated their studies at. So it's a really good source of information on home visiting. In order to be declared evidence-based by this program, you have to have met one of these 2 criteria. HOME-B outlines 8 domains, which I'll show you on the next slide. And you have to have either met outcomes made significant impacts in 2 of those 8 domains, or you have to show them in what they call non-overlapping populations. We actually in Kentucky did both, which I will show you on the next slide. We used Lexington, Bluegrass region, and Kipser region to show that those were non-overlapping populations. You couldn't be served or enrolled in both HANS in Lexington as well as HANS in Louisville. This is actually the summary of findings for the HANDS program. And so I do invite you to go on their website and look and compare what we show here to what other studies, other programs have shown. We actually are pretty consistent with the outcomes that we're showing. To date, we have shown positive findings, significant impacts in 4 of the domains: child health, family economic self-sufficiency, maternal health, and the reductions in child maltreatment. And we actually, part of where we have so many outcomes is because I was nervous about getting evidence-based status, we actually submitted studies to do both. So we submitted everything we thought was significant in the statewide and then did those sub-analyses for Lexington and Louisville. And I do invite you to explore their website. And so this now has led to HANDS. We have the lovely green check mark by our name on this website. We are an evidence-based model meeting the criteria. I was actually in Salt Lake City at a maternal child health conference the day we got this news, and I got a text message at like 3:30, 4 o'clock in the morning from Kylan, who is the grant administrator, because we've been monitoring it. We knew they tell you the day the findings are going to be released, but they won't actually tell you the findings. You go to the website. So this was a very happy day. So with all of this work, we have met criteria. We are very excited about that. And I think what I always say is, for me, it's really been important to show really the entire country the exceptional work that's been happening here in Kentucky. And being able to get HANDS to an evidence-based status, for me, has been the crowning achievement of my career. And I feel like I'm unlikely to beat it at this point, honestly. Partly because it shows the work that is, I'm just a data person, but all of the home visitors and everyone doing the great work. I've also outlined here some of the other studies that we would like to do. It is, there are always things on the agenda. So we would like to expand that statewide evaluation from 2004 to 2015. That would make it the largest study ever of a home visiting program. We also have plans to link, hopefully with Medicaid data if we can, to examine actual healthcare utilization, particularly emergency room use and some of those things, and then hopefully expand the kindergarten readiness study statewide. And with that, I am done, hopefully reasonably close to time. So I have included my email address here if you want to email me to have follow-up conversations, and then we'll open it for questions.
Great. Thank you so much, Dr. Williams. That was absolutely perfect. And just let me share our congratulations to y'all, because I know this has been a labor of love and brilliance, and so I appreciate so much all that you all have done. I have one question and would love, again, those of you that have questions or comments for Corinne and Sarah, please type them into the chat box, and you can also hit the little hand button on your webinar dashboard itself, and I will see your hand and I will allow you to pipe in to ask your question as well. So my first question to you is, a couple months ago, as you know, Dr. Shepard retired, and we wanted to make sure from the Pritchard Committee that we communicated to the cabinet that this was a high priority program for us, and wanted to address some of the pieces of evidence. But we also know that there's lots of positive outcomes, and we didn't want to write a letter that was 8 pages long. So I think as you're thinking about the different kind of outcomes that you've explained today, if there were 2 or 3 that you think are the most important for policymakers to really understand, which ones would you suggest that we really highlight?
I think the birth outcomes are probably the key thing, partly because there's so much evidence that reducing preterm birth and low birth weight has tremendous both cost savings, but also then impact on that child's life over time. I also think the other one might be the child maltreatment for similar reasons, that we know that preventing and reducing maltreatment can really shape that child's life going forward. And those are the 2 that have the sort of strongest evidence base behind them, so that you can rely on that to say it's not just us saying this.
Yeah.
There's that other evidence that supports making improvements, or these improvements being important.
Okay.
For improving health.
Perfect. Thank you. Thank you so much. Cindy Heine has sent in a question. She asks whether the results from the study have any relationship to the number of home visits made to a family. So is there dosage? Is there dosage effect at all?
There is a dosage effect. And so one of the things that we have done, and I didn't present it here because you get very quickly into the weeds with looking at engagement with hands, because it's sometimes a little bit more than just dosage. Right now we are looking at number of visits, and you do see actually with families that have more than 6 prenatal visits, their birth outcomes are much better than families that have between 1 and 3 prenatal visits. So there is, in fact, that dose response. For some of the other outcomes, we're also looking at time in the program. Because of the way if families are making improvements, they actually go to having fewer visits. And so number of visits isn't a great marker of that. And so we're looking at how to tease that out, looking at length of time and then progress made based on how often those visits are occurring. That was a sufficient answer.
Yeah, that was perfect. Thank you. And Patricia Tenen, thank you, from KYA, has asked, does hands have an oral health component? And if so, is that something that you looked at in the evaluation?
Are you talking for the children, I'm assuming?
I think so,
I think
yeah.
either way, the answer, at least on is it included in the evaluation, is going to be no at this point, in part because getting data on that on a statewide level, I'm not sure. I would be more than happy to see if we could figure out how to do something like that, because I do think that we know how significant oral health is for overall child health. And I can get back to you on whether or not there is, because it's not something I'm evaluating, I can't say for certain whether or not it's included in the curriculum. I want to say yes, that it is a component of the child health modules, but I am not certain enough to leave that as a yes.
That's great. I know Patricia would tell you too, it's a big priority for KYA and their work, so I think that would be lovely if you could look at that. Yeah. That's great. And another question from Cindy Heine. Was there statistical significance to the social emotional results on the kindergarten readiness assessment being the highest of the measures?
I did not compare across the domains.
Okay.
I think that's what the question is asking, and I did not do that yet.
Okay.
No, I did not compare across those 5 domains.
Okay. I think the social emotional domain is one that we really try to emphasize because it sometimes gets lost, and so I think that's a big thing we would look at. Yeah. I looked at language development in part because that was what for me was sort of that first trigger. Yeah. Looked at that a little more closely, but I can do the same first. That would be great. Again, it is preliminary, so I'm open to comments. We're kind of your focus group. Yeah, you guys are like you're actually the first people to see this outside of us, and so yes, please tell me. That's great. Terry Tolan, thank you so much for joining, Terry. Now that HANDS data is in the statewide longitudinal data system, and as is the Brigance, can you tell us any more about what it would take to get to a statewide study like you've done in the 2 counties? Is there anything we can do to help? So I actually I learned this just recently, and I was not aware that it was there. So I was pulling from the data when it's not yet included. And so, yes, I think that if there's a way of me getting identified information, that would be helpful. At this point, the challenge is we have to be able to link that statewide data with the HANDS data, and I'm pretty sure the HANDS data is not yet in that longitudinal, in that data set. Okay. So that would be the challenge if we have enough, if we have a way of linking, and it can be really hard with just names, and so we need some identifiers. Okay. But yes. And of those of us on the call, let's see, Janet, Patricia, and I are on the ECAC data subcommittee, so that might be something that we look into. I would love to talk and see if there's a way of figuring out if we can do that, because I think it would be really important to look statewide, and also then county by county to look at what different impacts we might have. And then if there's counties that are doing it particularly well, what might they be doing differently that we could then
expand to the other counties.
That's great. And one thing that I'll get into in terms of our updates from Strong Start is that we are really trying to broaden our scope a bit into implementation. And so if there were county level differences that were matters of implementation effectiveness, if there are ways that we can help spread that best practice.
I think the other thing that's a challenge right now with the kindergarten readiness study, just because I didn't have time to go through all of the limitations, but we don't know what happens in that interval between when they end hands and when they do that kindergarten assessment. And I think that could be really critical.
Yeah.
Because if there's maintenance of some of those activities that were developed in that early, birth to 2, that's going to be different than families who are just over hands and then have this gap.
Yeah.
And then, we're talking about the child care stuff,
yes.
That kind of thing can really play a role in those schools.
Wonderful. All right. Well, thank you so much, Corinne and Sarah, for being here. And it's great to have you all as partners in the coalition work. And thank you for all that you've done to bring such technical validity and fabulous use of the data as we all work together.
Thank you very much for having me.
Thank you. Great. And just a couple of other things I'll mention on the home visiting front. I did mention the letter that we sent. We are also involved in a community of practice of other states that are working to make sure that there's effective advocacy for home visiting. And so that's been a really great opportunity for us to learn from some other states as well. And I can definitely validate that we are way ahead of the game in terms of what advocates have been able to accomplish within Kentucky. So thank you to all of you who've been a part of that over the years. And also, as many of you know, McV is up for reauthorization. And so we have been communicating with folks on the federal advocacy side about what we can do as a state to send the right messages to our congressmen as well as others who are in the right positions and the right committees. My understanding now is with the new House, we have committee chairs in place, but we don't have committee makeup. So as soon as we know that, we'll know better who needs to receive letters from whom when, and we'll communicate all of that with you too. Because as you can see, McV funds are really making a difference in Kentucky, and so we want to make sure that that funding continues. So with that, let me go through just a couple of updates on the Strong Start side of things. So first of all, we have been working on our policy priorities for 2017. As we've discussed before, they will focus on early childhood partnerships as well as hands, and that was something that we heard loud and clear from coalition members, as well as supporting efforts to really bolster quality improvement as well as the early childhood workforce. We're making just some small edits to the document that you've already seen that outlines those priorities, and we'll be finalizing that for our next meeting. I also just wanted to share, we've spoken with you off and on about the early childhood provider cost of quality study that we'll be working with all of you on in the coming year. We'll be launching it in January, and our hope is to complete the report by August so that it will be really useful as we gear up for the budget session in 2018. We'll be developing estimates both for quality preschool as well as child care in a variety of different settings. And what we're trying to work through right now is just really setting priorities for where are the specific places where we need to provide policymakers with new rational-based evidence in terms of the cost of getting to different levels of quality. But all of this will be conducted in a very transparent way with a large number of you as well as a broader set of shareholders as well. We want to make sure that once these estimates are out there that they've been thoroughly vetted by all of you who are experts in this field. So we'll continue to share more information on that as we go. And finally, as I mentioned before, we always want to make sure to talk with each other about the implementation of all of these policies that we have at the state level and things that are spurred by federal funds as well. So many of you are working across the state and see how things are actually working on the ground, and we really want to make sure that we're bringing those opportunities as well as challenges to bear, so that we're advocating not just for new policies or new funding, but we're really advocating to make existing programs work better. So whether it's helping with enrollments in different programs or helping to make sure that certain communities get information that they need, as you have those ideas, please bring them to our attention, and we're hoping that we can create some real opportunities for us to work together overall to improve the success of our early childhood programs. Just a couple of upcoming events that I'll mention. Here at the Pritchard Committee, we are releasing our Top 20 by 2020 report on Thursday. This is our biannual look at where Kentucky fares on a variety of different measures as compared to other states. The real goal of this report is to make it clear that Kentucky absolutely can and should be at the top tier of states across the nation. And as you've heard from Dr. Williams today, we're certainly showing a lot of effectiveness on hands, and our outcomes can be there as well. And there is a preschool enrollment piece of that report, so I would really encourage you to look for that, and I'll make sure that you get that information when it comes out. We will next meet as a coalition in person January the 19th, again from 1 to 3. We'll be at Kia, and lunch again will be available at 12:30. We're a little bit off schedule because ECAC, we usually meet after ECAC, but ECAC got moved this December because they have a federal monitoring visit on December 15th, so they'll be meeting the afternoon of December the 16th. And I'd also so glad to have Patricia on the line. Children's Advocacy Day will be February 9th, so we'd encourage you to mark your calendars for that day and show up to share with legislators why all of this is a high priority for you. So with that, I'll see any questions, anything that anyone needs at this point. Oh, and I will, point of logistics, I will send out the slides from today's webinar in an email to you this afternoon. And so please feel free to share them with anyone in your network. And please feel free to contact Corinne with any questions and ideas. And again, as she shared, the kindergarten readiness and mortality data pieces were really preliminary data, and so she's really looking for feedback and looking for your good questions to help make it even better. So with that, we will close, and look forward to seeing many of you over coming weeks, and the happiest of holidays, and we'll see you January 19th.